my name is Juan. I'm going to be your physical PT today. We're going to be palpating various structures on your body. Is it okay if I touch you on kind of your chest, your hips, your neck, arms, legs, everything?
Yeah, sounds good to me.
Okay, cool. So let's get started. Okay, so first structure we're going to palpate is the PSIS. So to palpate the PSIS, I'm going to use the palm of my hands to locate the iliac crest. And I'm actually going to pull your shorts down. Is that all right?
Yep.
Okay. So I'm just going to bring these down. Okay, so I'm palpating for the iliac crest. I'm following them down until I feel these two bony prominences. This is the PSIS. So this level is good for locating the S2 body of the vertebral body. If you draw an imaginary line between the PSIS, you'll find the S2 body. And the PSIS is also important because it is one of the attachment sites for the posterior sacroiliac ligament. Okay, so from here, if we follow the spinous processes down, we could locate S3 and S4. Okay, and if we come just laterally of the spot, we will feel the inferior lateral angle of the sacrum. This is also an important spot because you will have an attachment for the sacrotuberous ligament here, as well as the long posterior sacroiliac ligament. So let me lift these back up. So now we're gonna locate the ischial tuberosity. But we do this by finding the gluteal fold right here. And if we just take our thumbs and press in, we will feel those ischial tuberosities. They're pretty prominent bony end feel. Ischial tuberosity is good because this is where we're going to find our attachment, our origin of the hamstrings, and there's also a bursa that lies here. Now coming back up, we're going to find the 12th rib as well as the L5 spinous process. So to find the 12th rib, I'm just going to take the palms of my hands and I'm going to push into this soft space. And I will find, there we go, a bony infill here. This is the 12th rib. It's a floating rib. And if we just follow this up, we should land on the T12 spinous process. So from right here, we're at the T12 spinous process, and this is nice because now we could work our way either up or down the spinal column for whatever we might be looking for. And our last site in this position is going to be L5. So L5, what I like to do is we come back to the PSIS here. We know we're at S2, and then we can just work our way up to S1, and we should land on L5 right here. L5 is a common site for back pain, for low back pain, and between L5 and S1 is the largest vertebral interspace. Okay, so next we're gonna start with some landmarks of the neck. So I'm just gonna take your head, just relax, okay? So first what we're gonna find is just the occiput, which is right here, it's the base of the skull. And if we come down from the occiput, there's going to be a space, and then the first bony landmark that we feel is going to be C2 spinous process. So this is a nice landmark to let us know, orient ourselves on the spinal column, and we could find some different landmarks from here. So right now we're at C2 spinous process. If we go laterally from this spot, we can feel the facet joints. And these facet joints, they are stacked on one another, which create the articular pillars of the column. This is an important spot because this is where our paraspinal muscles are going to attach. Additionally, if we get on the outside of these facet joints and we feel around in here, we could ask the patient if there's any tenderness, and if there is, this could be a sign of another pathology. So coming back to the C2 spinous process, I'm going to run my way down towards C7. And C7 is pretty nice to find because it is very prominent on our cervical spine. So right down here, I am at C7. From here, we could also locate C6. So to do this, we're going to put the patient into some passive flexion. and extension. And by doing this, we can feel the movement of C6. So when we put the patient into flexion, C6 will kind of push us out, and when we put them back into extension, it'll disappear. So that's how we can differentiate between C6 and C7. The last thing we're going to look at from this position is the first rib. So to find the first rib, I could take my hand and run down the side of his neck and push until I feel a bony end feel. So this is going to be the first rib. It's going to act as the base of the neck. And this is also important because the anterior and the middle scalene is going to attach in the first rib. Okay, so now coming back up, we're going to come down this way to palpate the liver. So to do this, we're going to feel for this costal cartilage. And if I just run my fingers over that costal cartilage, I should get a firm end feel. And I could ask the patient to take a couple deep breaths in and out. Good, and let's do that one more time. And this just gives me a better sense of where the liver's at. It kind of pushes me back out when he does this. Coming around to this side now, we're going to locate the ASIS. So this one is a pretty easy landmark to find. If we just use the palms of our hands, we should find it pretty easily. It's very prominent, very hard bony end feel right here. So this is the ASIS, important because the sartorius muscle originates here, as well as the inguinal ligament. So to find where the inguinal ligament runs down, we're going to take the base of our palm right here in the middle and just come down slowly, and we will feel another bony end feel. This is the pubic tubercles. So from here, the pubic tubercle, the inguinal ligament runs via the ASIS and the pubic tubercle. And this is actually acting as the superior border of the medial femoral triangle. Now the lateral border is from the sartorius. So sartorius also originates from ASIS, and it's going to run down the leg towards the pes anserine, which is on the medial aspect of the knee. So this is the lateral border, sartorius, and then the medial border is adductor longus. To find kind of where we're at with adductor longus, I'm gonna raise your shorts up a little bit, and I'm gonna put you into this figure 4 position. I'm gonna push down, okay, and you're just gonna hold that there. So by giving some resistance, this adductor longus muscle is gonna flex, it's gonna push out of it, and we could transversely palpate that and get an idea of where it's at. So you can relax now. So that, from the sartorius, adductor longus, and inguinal ligament, that forms our medial triangle, which is important because the femoral nerve, artery, and vein are running through there. So that's some important neurovasculature. And if we wanted to feel for the femoral pulse, we could in this area. So lastly, what I'm gonna have the patient do is roll over onto your right side. And we're going to palpate for the greater trochanter, kind of like the ASIS. It's pretty easy to find if we first use the palm of our hands to get a broad idea of where we're at. And from here, then we could use our finger pads to kind of get a little more detail of the greater trochanter. Important landmark because from here we got the gluteus medius and piriformis having attachment sites here. From the seated position, we're going to first find the AC joint. So coming from the clavicle, we're going to come laterally until we find that articulation between the clavicle and the acromion. So the AC joint is significant in that it is commonly injured and a separation is common in this area. Also, the acromion will then turn into our scapular spine. So now I'm running on the scapular spine here, and I'm going to have our patient put his arm behind his back. This is going to allow us to see the scapula a little more clearly. So now I could feel for the border, the medial border of the scapula coming down into the inferior border of the scapula. So with the scapular spine, we have trapezius and deltoid having attachment points here. And with the inferior angle, we have teres major as well as latissimus running through and attaching on the inferior angle of the scapula. So now if we're coming back towards this shoulder region, if we come back to the AC joint, and just drop off onto this soft tissue area, we're going to be at the subacromial space. So subacromial space is important because our supraspinatus tendon is running underneath the AC joint in this space and then attaches ultimately on the greater tubercle. The subacromial space also is a common site for impingement. So now if I am coming with my palm of my hand, I could get a feel for that greater tubercle. Greater tubercle is an attachment site for supraspinatus, infraspinatus, and teres minor. And the greater tubercle also forms the lateral border of the intertubercular groove. Coming more anterior now, we could find that coracoid process, which sits underneath the clavicle. We get a bony end feel here. Coracoid process is the attachment point for pec minor and for short head of the biceps. And now we're going to come down the arm towards the elbow. So if I get the patient into 90 degrees of flexion, it forms this cubital crease. On the medial side of the cubital crease, if we follow it, we're going to hit this bony prominence. This is our medial epicondyle, which is a attachment for the wrist flexor muscles as well as the ulnar collateral ligament. If we come on the lateral aspect of that cubital crease, we're going to find the lateral epicondyle. Lateral epicondyle is an attachment point for the wrist extensor muscles as well as the annular ligament. From here, we could start to find the radial head. So radial head is gonna be just inferior to the lateral epicondyle, and I could place my thumb on there and then my finger on the anterior side, and I could start to form kind of an idea of what this radial head is feeling like. So if I get the patient to go into some pronation and supination, I could feel that radial head turning in that space. Coming down the arm towards the wrist, first we're going to find the scaphoid bone. So if we go and spread our fingers out, this anatomical snuff box is going to present itself. And if I just push down into that space, I'm going to be at the scaphoid bone. Significant because it is the major weight bearing bone of the wrist, and it's commonly fractured in a fouche in a fall on an outstretched hand. On the other side here, if we locate the styloid process of the ulna and come just off of that, we are going to be on the triquetral bone. So the triquetral bone, if we come to the palmar side, is going to help us locate the pisiform. And from the pisiform, we could locate the hook of the hamate. These two bones form the tunnel of Guyon, which has the ulnar nerve and artery running through there. Coming down towards the lower extremity, we're going to start at the knee with the joint line. So if I come to this patella, I could start to feel that articulation between the femoral condyle and the tibial plateau. So if I keep running medially, eventually I won't be able to feel that joint line anymore, and I'm going to be on the MCL. Additionally, if we do the same thing on the lateral side, we're going to be able to find the LCL once that space is no longer present. From here, we can find the fibular head. So if I just take the palm of my hand and run on this lateral aspect of the leg, I'm going to find the fibular head right here. This is an attachment point for the biceps femoris, as well as the common fibular nerve that can be found just inferiorly to that fibular head. Okay, so now we are going to get the patient's foot onto the table, and we're going to find some structures on the ankle and foot. First, the talus. If we come from the tibia down, just follow this shaft of the tibia, we're going to eventually come off and into that talus. If we come laterally to find the lateral malleolus, from here we could picture the ATFL running from the lateral malleolus to the neck of the talus. This ligament resists plantar flexion and inversion, and it's the most commonly sprained ankle ligament. On this side, staying here, we could find the fifth metatarsal, so it's just going to be the most lateral prominence on the bottom of the foot here. So fifth metatarsal. If we come posterior to the fifth metatarsal, we're going to be on the cuboid bone. Fifth metatarsal also acts as an attachment point for fibularis brevis and tertius. Finally, if we come onto the medial side, if we drop just from that medial malleolus, we're going to be on the sustentaculum tali. If we come anterior to that point, we're going to find the navicular tuberosity. Between these 2 points runs the spring ligament, which helps support for the medial longitudinal arch. And the navicular tuberosity also serves as an insertion point for the tibialis posterior.